Good morning.
Good morning, sir.
Good morning.
Good morning, sir.
You're welcome to our today's class. Today we take a look at action and uses of medicines. As usual, we look at the questions we answered and take the questions one after the other. Then analyze the questions and pick the most appropriate answer and the reason for the answers. Then we mark. Please, I want us to concentrate here. I don't want us to see sideways again. Come here. Let's be together here, please. What's that? Let's shift a bit. I want us to be. And let's stay here. Let's maintain this length. Very important to me now. Not when others will stay here within what I don't know. And if you discuss, I'll catch you straight. Sit down there. Let's be together. Very important. Please, this is where you came on. Have you repented?
It's not because I told you of this morning.
Okay. You check that out. Please.
End of session something from all of you in this class.
Please be doing that, please. Very important. Please come here. Shift. Shift.
Shift.
Don't worry. I will tell you how to sit now. No. Did that? Come here. Good. Until then, I will know what the rightful place for her to stay. If she starts disturbing you, or you take. All right. So now let's look at the questions. Are we together?
Yes, sir.
Please, let's be. If you are not. Okay, the question number one. Please, focus, please. There's time for everything, please. Question number one says what?
Which of the following cholineblocking agents is used especially as an anti-asthmatic?
Okay.
A. Atropine, B. Ipratropium, C. Platifilin, and D. Metacin.
What's the answer?
B.
B is what?
Ipratropium.
Why did you choose B?
Atropine. I think atropine. That atropine. I'm thinking maybe it's like all these.
Do you even know what is cholineblocking agent? So how did you arrive at the answer when you don't know what cholineblocking agent means? It just from themselves, you know.
Let me tell you my own reason. My own reason is I have a patient that is asthmatic patient. And so out of his drugs, so they recommend this for him.
What?
This Ipratropium. Like the man he can't breathe very well. So they now suggest, and he cannot eat. I think he cannot eat.
But is that a reason? That can never be a reason.
Say Ipratropium.
Why?
Anticholinergic.
Anti what?
Anticholinergic. Anticholine.
Okay.
It is a bronchodilator and is for the treatment of COPD.
Good. Muscarinic M is muscarinic.
Sir?
Muscarinic is M is muscarinic.
Sir?
M is muscarinic. I'm telling the meaning of M. So if cholineblocking is it just sitting as say anticholinergic. Is that clear? Okay. So
the also known as is
Negligible agent, yes. You know the one I
I go through my explanation. If I should write down on it's like chat give it
you are you are still fighting for your mark.
Yes, now because what everything that I said itself is inside the definition.
What do you say?
I said that the patient cannot breathe back the recommended because of his lungs something. And I also said that he cannot eat. So it's now bronchodilator.
Wait, let me understand something. You say hypertrophium. I ask you why. You say because you saw it in a prescription bar of a patient. That's the reason. So that means if you're not opportune to see it there, that means you don't know it now. So the point is that is to go straight. Tell me what it does. That's all. That's what I expected to see. The making of action, is that clear?
Yes.
Yeah. Even from them, you know, is that clear? So I agree with you. The answer is what? But why is not atropine? Why is it not?
Atropine is a
Taliphylline. Why is not metacin?
no.
So let's start with atropine. Tell me what you know about atropine.
Atropine is an opioid.
You say what? Opioid what? What? Is that right? That's why you are here. Okay. All right. So now let's go. Let's look at it. Let's take them one after the other and see how far we can go before our time elapses. How many people got that one? That from one. All of you. You should, but I think we mentioned it some time ago, right? So let's look at atropine. Yeah, atropine is anti-muscarinic. We know. It's actually anti-muscarinic. Atropine, yes. But the problem is that yes, it has systemic effect, but it's not suitable for routine asthma treatment due to its side effect and what have you. Is that clear?
Yes.
So it's not really for, so the drug may have a mechanism of action that may be okay for a particular treatment, but other things surrounding the drug may make it not to be used. Other one may be preferred use. Is that clear? So I'm not saying, I'm not disputing the fact that it is anti-muscarinic, but it's not for. Is that clear? It works more. Where does atropine works more? What preparation do you see it more?
Is it sorry?
No, talk.
Is it during surgery?
Not really.
Not really.
The share is for
Pains? No.
It sounds fine.
Have you ever looked into most of the ophthalmic
Okay. For
preparation?
maybe for I think dilation of the pupil,
For eyes,
It's why atropine.
pupil dilation.
What's the name of that pupil dilation? What is it called? Is it mydriasis or is it miosis or mydriasis? Which one? Are you sure?
I guess.
Check it up.
Yes.
which one are you writing?
M1.
Mydriasis refers to the dilation of the
Dilation of the what?
Of course, you know that most anti what is it called? Anti muscarinic or coronary they have this relaxation effect. True or false? They relax. Is that clear? And that's why they employ what? Broncho the dilation. So the same thing now, pupil mydriasis also requires what? Is it the relaxation or constriction?
Realization.
So have you not seen where it is now applied? Local effect instead of systemic effect.
pass through the bloodstream.
Right. So now, B, this second option there is hypertrophy. We have discussed that before. It's a quaternary ammonium what derivative. Listen carefully. Hypertrophium is a quaternary. You know, we have primary, secondary, secondary, tertiary, and quaternary. Quaternary ammonium derivative of what? Atropine. Note that point. See, there's something I want you to understand. We have been talking about this in drugs now. When a drug be shown to have effect that is not that wonderful, some modification can be done to create another one that may have a better structural structure and activity effect.
I don't know if you can be going one by one.
When do you want to go now?
No, because the way
Why you don't go and meet and say, okay, George,
Come on, time to my
Okay.
you want to know that.
So I will just
All right. So where do we stop?
atropine. We are still talking about
Hypertrophy we are talking about.
Okay. I said that I was trying to let you know that hypertrophium is a derivative of what? Atropine. Is that clear? It's a quaternary ammonium derivative of what? Atropine. So normal, it blocks the what? The muscarinic receptor. Is that clear? Muscarinic receptor. Of course, muscarinic receptors. Of course, now they are what? Muscarinic acetylcholine what? Is that clear? Yes. That's what they block. Specifically at the where? Respiratory airways. Are we together? As at the what? Respiratory what? Airways. So it's actually inhaled. Is that clear? It's inhaled. Yes. And it relieves bronchospasm. Of course, we discussed it at length. So no need going back there. Bronchospasm we see in asthma and COPD. What is COPD? No, it's not. Chronic what?
Chronic obstructive pulmonary disease.
Good. So this is because it is actually poorly absorbed systemically. Please note this point. It is poorly absorbed systemically and it has minimum side effects. So I've told you why atropine is not the answer, right? Then this platyphyllene. This platyphyllene, that one is mainly used in what? Gastrointestinal what? Spasm. Not for what? Asthma. Is that clear? All these things are anticholinergic, but the point is that where they are used matters now. It's different. Is that clear? Yes. Metacin is also anticholinergic, but it's older this thing, and this it has more side effects, no more systemic effect. Is that clear? Now, but it's not typically used for asthma anyway. So that's the point I want us to note on this. Just few points. You can expand on that, okay? You can study more. We cannot, if we stay and start discussing that one alone, we will not be able to cover. So we'll cover as many as you can. Then on your private studies, you can now go deeper. Is that clear? Sorry, there's no much time. I don't know what else to do. This is the only method I think I can use to touch a lot of things at the same time. Number 2 says what?
Indicates the side effect of theophylline.
Okay.
A. Bradycardia.
Okay.
B. Increased myocardial demand for oxygen.
Okay.
C. Depression of respiratory center.
Okay.
And D. Elevation of the arterial blood pressure.
What's the answer? What's the answer? Good. You are smart. Good. I like that. Maintain it. She didn't need to be told. She knows exactly what to do. Stretch. Sit there. How is your leg? Sit exactly behind her or her. Exactly. Don't. Did you get that as architect to get?
We close very late, so
Okay. You close it. When did you close it?
7.
yeah.
After 7.
Are you serious?
Yes.
Why? What happened?
That was
Study.
the
Huh?
That was when training left us.
and before
When did it start?
It was not long after you left.
around after
Wow. So you get had up to 6 hours class. Mado.
after everybody is gone.
Mado.
You.
People are trying. Long classes. I don't like long classes. I don't like it. I believe in short class. I'm consistent but
Just
short.
for the meantime now, in the next few weeks now, we are already
Me,
done.
no, me personally, to me, I feel that I'm just wasting my time. Once this place clock, once it's off, it's off. I don't know, maybe wrong, but that's what I feel.
Last year, they were leaving 8 man in the midnight.
If you are trying,
That's what they call us pillar.
keep it up. We are trying. Me, even when I was in school, all those long classes, I don't like it. Even as a student, come and teach me at the odd time. Even as a student, I don't like it. Once I stay the number of hours I can take. If you're talking, I'll just say, excuse sir. I go my way. Straight. I don't waste time.
I can tell you excuse me, sir.
Go, no. Yes, it's your right. I can't force you to stay in my class. No. If you're not following again, instead of staying in class,
Excuse me, sir, I want to go out of the
instead of see, I even personally encourage students to do it. Once it's not entering, don't stay in class and be doing nonsense in my class. Just go. Maybe if you can say come back when you're okay, it's okay. If you cannot, go. But I get mad at you when you're in my class and you start distracting me, because that is the next thing that will happen. Once you are off, you start unknowingly you start distracting, and that others that does that much
Whether she's off or at least she's on.
without even knowing what she's doing. All right, so number 2. Okay, we are number 2, right?
Yes.
So what's the answer? Madam,
Depression of respiratory center.
what's the answer? Why did you choose that answer? Let us know.
Explain to us.
Okay, because you think so. No. We're not talking about what you think here. Is that clear? So tell us with evidence. Why did you choose that? Come into my heart, Lord Jesus. He will. Oh, you answer.
Please,
You. What did you answer there?
Shame me. What did I accept?
You don't know what he answered.
I chose elevation of arterial blood pressure.
All right. So now let's look at the options. The first option says bradycardia. What do you understand by bradycardia? Slow. Are you sure it's not tachycardia?
No, there is persistent increase in
So bradycardia and tachycardia. What is the name they call it? There's collective name. They call.
Contents. Medical. Is it medical terms?
Are you? Is it hypertension and hypertension?
Two of them, they have a name. They are issues. Hope you know. Both bradycardia, they are issues. They are not normal. So they are called.
Okay, they are hypertension. They are called.
Dysrhythmia now.
Cardiovascular.
Dysrhythmia.
Dysrhythmia.
Sweetener.
You are dead.
Condition where the heart beats too slow, inferior than 6, and the side effect of that one is vomiting, gastrointestinal.
So what it means that normal rhythm is now thwarted. So it can be higher or lower than normal, higher than what? No. So it's a but the higher one, and so the rhythm is in disarray. Is that clear? Is in what? Disarray. So actually, theophylline does not cause bradycardia as a side effect. Instead, it causes what? Instead it causes what? Tachycardia as side effect. Please note that point too. Instead, it causes what? Tachycardia. So he is not A, right? B says what? B says what? Increase myocardial demands for what? Oxygen. So what activities in the heart? What are the activities in the do you think can lead to possible myocardial oxygen demands?
When there's no enough oxygen in the blood.
No, I said activities, not condition. We know that activity and condition are not the same thing. Activities and condition are not the same thing, right? Okay. Drug-related activity. Let me put it that way. Drug effect in the system that can lead to increased oxygen, myocardial oxygen demand.
The drug.
Yes. Okay, you've not heard that, right?
No.
Okay. Okay. No, I thought she was actually talking to us. No, you were saying something. I thought you were talking to us. Huh? Xanthine. We know theophylline is a what? Theophylline is a what? Xanthine what? Derivative. Hope we agreed, right?
Yes.
Yeah, that one day. But we are talking about linking to what? Increased myocardial or demand of oxygen. So that's where we are going to. It stimulates the heart rate and CNS.
So the answer is B.
So can we link this? Remember I said that theophylline has tachycardia as side effect, right?
Yes.
So here now it stimulates what?
The heart.
It stimulates
The heart rate.
the heart. Is that are we together? Now it stimulates what? The heart and what? CNS. Is that clear? So because of that now it can lead to what? Increase in what? Heart rate and what? Contractility. Have you not seen why the side effect can be what? Can lead to what? Tachycardia. Is that clear? See, because it can cause what? Increase in what? Cardiac what? Contractility. Is that clear? Because it can cause it, so it can actually lead to as a side effect, like what? Cardiac. It can go overboard and lead to what? Tachycardia. Now, so these two effects now, effect on the heart, increasing the cardiac contractility and what? CNS can actually lead to what? Increased demand of what? Oxygen. Is that clear? Because more oxygen will be needed for these activities. Is that clear? So that's why that is actually what the answer. The answer is what? B. But I'm just trying to let's look at the other options and see what depression of what? Respiratory center. There are this group of drugs that are notorious for this depression of what? Respiratory center. What are they?
Respiratory depressants.
Example now. Which are the best example? Okay. We'll get there. But just know that this one, the theophylline does not do what? Depress what? Respiratory what? Center. It only theophylline does not depress respiratory center.
So like which medicine will not cause types?
Maybe we are in the class when we talk about opioids.
Okay.
Have you forgotten what we discussed? We mentioned opioid as the depressing respiratory is a major. We discussed it. But theophylline does not depress what respiratory. In fact, it stimulates it. It stimulates what respiratory center. Is that clear? What of the other one? What is it called? Elevation of what? The arterial blood pressure. Does it elevate arterial blood pressure? Yes, even though yes, one can actually, say because of trying to just theoretically try to link up increase in cardiac contractility with blood pressure, but it's not really a must. It's not really something that is standard that it increases what arterial blood pressure. Even though yes, that contractility can contribute, but it's not a how do I put it? It's not a prominent effect. That is the right way to use. It's not a prominent effect. So the answer is what? B. Number three says what?
All of the following drugs are inhaled glucocorticoids except A. Triamcinolone,
Okay.
B. Beclomethasone,
Okay.
C. Sodium chromoglycate, and D. Budesonide.
That's it again, please.
C. Sodium chromoglycate.
Chromoglycate. Is that clear? So what is the answer?
The answer is A.
We discussed this. It cannot be A. It can be A. Why do you say it cannot be A?
Because A is mostly used as
external
semi-solid
like steroid
for skin.
So have you not also see beclomethasone in triple action cream?
It's there.
So
you cannot. It's only for local action. You cannot work
for only who says who? Prove it. Oh yeah.
I'm just saying.
Give me evidence.
I'm just saying. You said if you say something.
No. No, the way she said it sounded so.
You're saying only.
That's where I'm going
If
to.
you're not sure, you say proper.
She said she can only be.
Also.
It can is it cannot. It is only. So she was speaking authoritatively.
All right.
It's what? Yes, I like that.
So what's the answer?
Okay, you asked me the answer.
Answer is A now.
Answer is
Yeah? Is what?
A.
Thank God. All right, please, triamcinolone is an inhaled word. As far as asthma is concerned, is that clear? Asthma, yes.
What?
Can you search your phone? No, search. No, search. The word is in our palms. Gone are those days when a student will be saying something opposite to what lecturer is saying. The lecturer will say, "Shut up your mouth. Are you going to tell me to teach my work?" No, look it up. We are free. Let's discuss it. It's not true. We discuss it.
Another generic for brand today. For this try.
Okay, it's in here, right? Good. So he's in here, right? Did we discuss it some time ago? Yeah, Missy?
Yes,
Okay, we discussed it.
Yes.
Thank you. All right, so now, so A is not the answer, right? Because triamcinolone is what? Inhaled, right? Even though, yes, You can still see it in some formulation for even acne. True or false? True or false? Acne, right? There is cream they call acne way. What is the content? Who knows the content of acne way?
Translumin.
You can also have it there. Yes. Even beclomethasone can be seen in some triple action cream. True or false? Yes, but it also what? Inhaled for as far as asthma is what concerned. You cannot go and start applying it, rubbing it on the respiratory pathways, right? So it can be what?
It is also a corticosteroid, but it's not an inhalation.
What's that?
That's translumin.
Yes. They are all what? They are all corticosteroids. So the second one is what? Beclomethasone. Beclomethasone is also corticosteroid. It can be found in the cream. They incorporate it in most cream for anti-inflammatory effect on the skin. True or false? Yes. In some skin conditions, yes. Then it can also be what? Inhaled, because you cannot rub it on the respiratory pathway. So the only way to let it get to that place for the same effect is what? Through what? Inhalation. Is that clear? So beclomethasone is not the answer. Is that clear? Because we are looking at this with respect to asthma treatment, not in general now. The third option was sodium what? Chromo what? Glycate. This one is not inhaled. Is that clear? It's not what? Inhaled. Is that clear? It's not a what am I supposed to say? It's not even a corticosteroid in the first place. So that one apart. It's not a corticosteroid. You know that corticosteroid is part of what? Glucocorticoids. Hope you know. Good. So that one is not even a what? So what is it? God bless you. We discussed this, right? So it had effect in the respiratory pathways through another means. Both of them are act on what? Are anti what? Inflammatory. But this one now is through mast cell stabilization. Because if it stabilizes mast cell, what happened? Tell me what we discussed about that. If the mast cells are stabilized, what happened? Say what? No, it's simple now. Just take us back again to the what is it called? The pathophysiology of asthma. Take us a bit. What happened in asthma? What actually happened? There's something a very important aspect of step that normally lead to this inflammation. What happened?
Bronchial constriction.
Does
bronchial constriction.
Does bronchoconstriction lead to inflammation, or is it inflammation that lead to bronchoconstriction? What lead to that inflammation?
Mast cells.
How? What happened to mast cells?
When they are being released, probably by a trigger, and then they are released into the.
When mast cells are released?
When they are. When they are.
This sounds funny, but I'm hitting the point now. We are laughing. Let's discuss it.
The mast cells causes inflammation of the bronchi.
How does mast cell cause this? No, I discussed it in detail that day. That's why I'm asking you this question like this. Anything I know that you have even done in class or we discuss here, this is how I come.
Throughout the body, particularly near blood vessels, nerves, and lines of the lungs.
Please, what do we say about mast cell? Ibisi, tell us what you said about mast cell. Say what you said. Come here.
And other chemical the mast cell.
It's not true. Go here. What happens? Sorry, no verse. You say what?
What I wrote down that day, I wrote that it works by blocking the release of acid.
What works like that?
And other chemical.
What works like that? What?
Mast cell stabilizer work by blocking release.
No. I'm not talking about mast cell stabilizer. I'm talking about mast cell itself. How does mast cell? What contribution does mast cell have?
It causes allergic reaction.
How does it cause it? What does mast cell do that lead to what? Inflammation.
Mast cell contains granules fused with various mediators,
Very important point. They contain these mediators. Remember, when there is trigger now, mast cells will be what? Release. Mast cell will release these inflammatory what? Mediators. Am I communicating? It will release inflammatory what? Mediators. Histamine is there are many of them. Is this inflammatory mediators released from mast cell that will now lead to what? Inflammation. Mediator. They mediate inflammation. Is that clear? Now, mast cell stabilizers. That one that will now go and stabilize the membrane of mast cell so that they don't do what? Release those things that will go and cause what? Inflammation. So this is how they cause their own anti-inflammation. This is how this is how mast cell stabilizers cause their own anti-inflammation. Is that clear? So both corticosteroids, mast cell stabilizer, they all cause anti-inflammation, but not through the same pathway. So that's why sodium chromoglycate is not a corticosteroid, even though it causes what? Inflammation. It's a mast cell what? Stabilizer. Is that clear? So now I'll pick that C as the answer, but let's look at the fourth option. Option D says what? Option D is what? Bude what? This one is also an inhaled what? Corticosteroid. Is that clear? Yes. So sodium chromoglycate is a mast cell stabilizer, is not a corticosteroid. So it prevents what? The release of anti-inflammatory what? Mediators. So once the mast cell is stabilized, their cell membrane will be kind of stable, more stable, that they can resist effect of opening up and releasing what? The inflammatory what? Mediators. Is that clear? Number 4 says what?
Choose the drug belonging to membrane stabilizing agents.
Okay.
A. Xylotine.
Okay.
B. Sodium bromoglycate.
Okay.
C. Staphylococcus.
Okay.
And D. Montelukast.
What's the answer?
Sodium bromoglycate.
Sodium chromo what? Like is the answer. We have discussed it in detail. What do you know about xylotine? Xylotine, have you heard of it before?
No.
Okay, sorry, I forgot. Please come and pick, please. Come and pick, sorry. Have you collected? Please, give them, please. Have you heard of it before? No, yes, which one? I said head. I didn't say look, I said heard of it before. Okay. And now, we are still talking about what? The same anti-inflammatory, but through different routes. Is that clear? Two different what? Routes. Madam, stay here, please. I want us to be together. That way is okay. Come and take. Okay, you take already. Sharp. Now let's look at what is it called? Okay, xylotine, right?
Yes.
Yes, it's also it does its own from another point of view, but everything still boils down to us anti what. So what does this one do? It's a lipo what? Lipoxy or lipoxygenase. Lipo. Of course, you know where lipo is coming from, right?
Yes.
Oxygenase. Inhibitor, okay? Inhibitor. So this one, what it does, it blocks leukotrienes. It blocks leukotrienes what? Synthesis. Leukotriene synthesis. Of course, you know that leukotriene is also there. Leukotriene is a prostaglandin. Hope you know. It's a prostaglandin. Hope you know.
Yes.
You are aware, right? Good. So, okay, know it now. It's a prostaglandin. So that is what it does. Is that clear? Then it's not the answer, but the answer say the one that mast cell what? Membrane the question talks about what? Membrane what? Stabilizer. So it's not a membrane what? Stabilizer. It's a lipogenous what? Inhibitor that block what is it called? Leukotriene what? Synthesis. Now the second one says, option B says sodium chromogranulate. We have discussed it at length, right? So is the answer. But let's look at option C. Option C says Zafi what? Lucas. Please look at it now. Both Zelotin and what? Zafi Lucas, they target leukotriene. But it's not through the same pathway. Is that clear?
Yes, sir.
Zafi Lucas is what? Leukotriene receptor antagonist. So if let's assume Zelotin fails to do what? Prevent the synthesis now. This one will go and wait for it at the receptor end to prevent the what? Binding. Is that clear? So it's a leukotriene receptor antagonist. The same thing with what? Montelukast. Montelukast is also what? The same receptor what? Antagonist. The answer is what? B. Sodium what? Chromoglycate. Hope you are still marking. Number what?
Number 5.
Read.
Which of the following NSAIDs is a propionic acid derivative?
Okay.
A. Ibuprofen.
Okay.
B. Indomethacin.
Okay.
C. Metamizole-anagin.
Okay.
And D. Diclofenac.
What's the answer?
Ibuprofen.
Ibuprofen. We have discussed this at length too. Most of the things, questions we have answered now, we have discussed them. So I don't know. You have no reason not to score this in 100 of 100 for it. For it, you have no reason not to score it 100 of 100, unless you not go through what we did. Okay. So now, ibuprofen agreed is a classic what example of what? Propionic what? Acid what? Derivative. Now, indomethacin is that indole from the name. Indole what? Derivative. Is what? Indole derivative. Indomethacin is what? Indole derivative. The option C, metamizole, that is the popular anagin, is what? Is a pyrazolone what? Pyrazolone derivative. Pyrazolone what? Derivative. While diclofenac is acetic acid what? Derivative. Acetic acid what? Derivative. Diclofenac is what? Ibuprofen propionic acid. Ibuprofen propionic acid. Indomethacin indole the derivative. Metamizole, pyrazolone the derivative. Diclofenac, acetic acid what? Derivative. So acetic acid derivative. So the answer is what? The answer is what? A. Number 6.
Non-narcotic agents cause A. Respiratory depression. B. Antipyretic effects. C. Euphoria. And D. Physical dependence.
What's the answer?
Just B.
B is what? Is B? B is what?
Antipyretic effects.
Antipyretic effects.
Because respiratory depression, euphoria is for narcotics and analgesics.
Can you go back to what we? Can you go back now? I think that should be number what question? It was mentioned.
Number 2.
Number 2. Okay.
That's C.
Okay. Good. That depression, right? So now let's look at it again. Let's look at it. Option A. What does option A say?
Respiratory depression.
We have discussed that one at length, right?
Yes.
In fact, respiratory depression is a hallmark. In fact, is a common side effect of what? Narcotics, opioids. Is that clear? Opioids like morphine, like what? Morphine, typically morphine, but it's not a non-narcotic what? Side effect. Is that clear? So that is not it. That is why A is not what? The answer. B says what? Antipyretic effect. Actually, non-narcotic analgesic, like things like paracetamol, or even some of the, even other NSAIDs, they have antipyretic what? Effect. True or false? So they relieve fever, whatever, without affecting the central nervous system. They do their own peripherally, not centrally. That's why if you take paracetamol or diclofenac, you not go and start dancing. Is that clear? Or feeling tipsy or drowsy. Is that clear? No.
Yes.
That's why you not go and start feeling that, because they have no effect in the center. They don't act centrally, they act peripherally. Focus. Peripherally. Okay, now, so of course you know what euphoria is now. For you to answer this question, you know what that your highness feeling, even when His Royal Highness, even when things is obviously bad, you are feeling that there is this saying in a from where I'm coming from. Let me translate it in English. It says that the water in a pot or something like that is there, will remain there for the dog. If you like, let it jump up, jump down. What is there waiting for you. So if you like, go and high. After high, that problem is there looking at you. You must solve it. When you're high, finish, you load, the problem is there looking at you. So what instead of high, why not focus on the problem and solve it? Is that clear? So now, so that's what euphoria is. So because they don't have this central acting effect, all this euphoria, all this euphoria, sedation, as a sort of central what? Nervous system what? Effects. So, and they do not depress what? The respiratory what? Center too. So they are mainly what? Anti-what? Pyretic and anti-what? Inflammatory. Of course, you know what they do to prostaglandin what? Synthesis, right?
Yes.
Good. So, and then they also act at the hypothalamus to decrease what? To work on the temperature what? Temperature what? Regulation. Thermal what? Regulation. All right. Now, so they don't have physical dependence. Do they? They don't. That one is pure. Wait, I don't understand. The later person is not in your class.
She is, but she's not important. Dad, we want to check results.
Okay, she not okay. So it's not what a characteristic of what is pure. Is a pure characteristic of what? Opioids, not what? Non-narcotic analgesics. All right, the next question says what? That should question number what? Seven. All right, 7 says what?
Which of the following opioid analgesics?
Sir, the answer is B. Yes.
The answer is what?
B.
B, yes. Number 7 says what?
Which of the following opioid analgesics is a strong mu receptor agonist?
Mu receptor. Mu receptor. It's not mu, it's mu receptor.
Mu receptor.
Yeah, okay.
Agonist.
Okay.
A. Naloxone. B. Morphine. C. Pentazocine. And D. Buprenorphine.
What is the answer? What's the answer? Silence everywhere. No, silent morning. What's silence morning? Oh yeah. Talk to us. Okay, there's space. Oh yeah, I want to walking like this. Oh yeah, talk to us. You've not been contributed in my class, but after quiz you'll be scoring 60. Why? How? God's work. Hello.
Hi.
There are people that don't contribute in this class, but after quiz they'll be scoring 60. I asked one of them. She said that is the work of God. You say what? I talk to me now. I am listening. What's the answer?
Because it's a strong analgesic opioid receptor. Big answer.
So why?
Because it's very strong. You see, let me say it.
Reason for your answer is
Also known
it's always
as
funny.
opioid receptor. It's a type of opioid receptor that play a significant.
No, what you are reading is not wrong. But link it to the question. That's where I'm going to now. Why is it the answer?
Which of the following opioid analgesic, all opioid analgesic, is a strong.
Strong. I don't want. Leave her.
What's a strong Judah now?
The one is very strong. Continue strong. Continue. We are with you.
It also have a good effector. Morphine is not a thing that you can just say anyhow.
All right, it's okay. You are time to answer. You are time to give it to you to answer as a laughs. Let's look at the options because we are not getting any tangible answer here. So let's go. No, she actually has a point. Let's look at the options. So anytime. So let's look at the options, okay?
Yes, sir.
Option A says what? Naloxone. Actually, naloxone is an antagonist. It's not an opioid. It's not an agonist. It's opioid what? Antagonist. That's why naloxone is normally used for what is it called? Overdose, treatment of overdose of what? Of what? Opioid. Is that yes? Naloxone is an opioid antagonist. So that's why it's used in what? As opioid what? In opioid overdose because it's an antagonist. Is that clear? It's not an agonist. Okay. So it's not an agonist. So please note that point. How are you? So it's opioid what? Antagonist. So it's used
for treating
overdose. So even from them, so it reverses what? The opioid what? Overdose. Now, so it's not the answer, right?
Yes, sir.
B says what? Morphine is a potent. Please, this new. We are able doing this in the class in the hall doing seminar, doing second year seminar. We are there. That one they did some time ago. Have you seen? It's important to attend all these things. It doesn't matter. Please, there shouldn't be class at that point. It's an academic exercise.
Yes.
And in such an academic exercise, topics were distributed to different people. Please learn this thing now, please. Anytime, any place you are, and there's opportunity for conference, seminars, please don't miss it. Because different topics were shared among different people. So what it means that if you attended all of them, or at least 90%, you learn a lot of things from different brains that did research on different topics. And this opioid, I think those I supervised, they presented on this word, opioid. Is that clear? Morphine and rest of them. Now, this mu is one of the opioid receptor. Is that clear? Opioid receptor. So, yeah, we have kappa.
Mu, delta, and kappa.
Mu, kappa and delta, good. So mu is one of them. Is that clear? Yeah. Now, so morphine is a potent mu opioid receptor agonist. Is a potent mu opioid receptor agonist. Not antagonist, please. It's naloxone that is what? Antagonist. So this one now, basically, by binding it to receptor, what does it do? It helps to bring down what? it causes what? Analgesia. Is that clear? Analgesia. And of course, euphoria with the attendant what? Euphoria is there, right? Good. And the respiratory what? Depression. So because of this effect now, we'll pick what? Morphine as the what? As the answer. Is a strong mu what? Receptor agonist. Now, pentazocine is not strong at mu receptor. Is that clear? In fact, it has a mixed agonist antagonist effect. It's mixed up, so it's not. Now, buprenorphine, this one is a partial mu what? Agonist. It's a partial mu agonist. So it's not as strong as what? Morphine. Is that clear? So the suitable answer there is what? Morphine. B. Number 8.
Which of the following drugs used in the treatment of gout acts by preventing the migration of granulocytes?
Okay.
A. Allopurinol.
Okay.
B. Sulfipyrazole.
Okay.
C. Colchicine. Colchicine. And D. Indomethacin.
Again, please.
Which of the following drugs used in the treatment of gout acts by preventing the migration of granulocytes?
Okay.
A. Allopurinol.
Okay.
B. Sulfipyrazole.
Okay.
D. Colchicine.
Okay.
And D. Indomethacin.
What is the answer? Did you do? What already your face?
This is
You get us.
Yes. Yes.
Now God know where you go bring those questions.
Didn't you do musculoskeletal system drugs?
Not the drugs, but the anatomy.
Please, if you know it, go and study, go and read it too. What I brought it so as to open your eyes in that direction. It's one of the things you should know too. Is that clear? Yes. Apart from the antipyretic, analgesic, you have to know the one for arthritis, gout, and all those things. It's part of what you should know. It's very important. You should know it. Not just about exam alone, even in your practice. In your curriculum, you should know it. You see a lot of them in pharmacies. True of us? Yes. So you should know it, please. Very important. Sorry, I am only opening up some things that opening your eyes to things. It may be difficult, but it will lead you for you to go more and do what? Study them and get yourself equipped. Very important.
This thing of Benadryl, is it a musculoskeletal drug?
Laxant. Down with Laxant. Yeah, it is musculoskeletal because muscle is there. Exactly. Musculoskeletal, under musculoskeletal, we are the one that act on the muscle and one act on the pure joint, skeleton, and system. Exactly. Am I communicating?
Yes.
Good. Now. Okay, so since there have been silence everywhere, let's look at the options. Option A says what? Allopurinol. So allopurinol is a xanthine oxidase inhibitor. It's a xanthine oxidase what? Inhibitor. So what does it do? That one just lowers what? Uric acid level. Is that clear? Xanthine. You know that uric acid oxidase inhibitor. Uric acid accumulation here on the major cause of gout is from uric acid accumulation. Hope you know. Is that clear? You know that one, right?
Yes.
So this one now act on what? Xanthine oxidase to lower the what? The uric acid level. Is that clear? So it is not.
That means gout can be traced to kidney problem then.
Okay. Yes, yeah. Accumulation stones can be formed, right? Is that what you mean? Yeah.
Because the kidney is supposed to filter out uric acid.
Yeah. So all those things. Yeah. Are we together? But at least you have to be specific of the kidney issues. Is that clear? Is this stone? Is that clear? Not every kidney issue. Yeah. You know, kidney we have a lot of. Some kidney issue can be infection. True of us. So it depends on the one that lead to it. The etiology of the issue at hand. Now, so the answer is not what alloporinol, because they're talking about what migration, exactly, of granulocyte. That what are granulocytes? What are they? Don't want to get there.
So I say it now, and I say we get there first.
Type of white blood cell characterized in their
Oh, Kawala will come in Lara. Type of what?
They are enzymes that help fight infections and inflammation. If you're not gonna say what you said.
Am I a problem? See when you're attacking yourself.
That's right. Teachers that be like in primary school, when you get there,
What is it now?
Honestly, it's frustrating. Like out of say 25 questions,
You go answer how many questions?
I only answer 4. Like I know say okay, that's 4.
I know how you feel. Wait. I know how you feel. But we're coming down now. I'm here. I am here with you. You know, so there are some things you say. You keep jumping up and down, going up and down. We are still on the question. I will get to that point. That point I'm making now.
curiosity kills the cat.
No, I understand his issue. There's what we call ATA in our own side. I don't know what you call it here. ATA means exam difficulty.
It's annoying. Even reading the questions,
You're welcome to what pharmacy. You're welcome to what. I am officially welcoming you to what pharmacy.
To catch them.
She will not bring this one out.
I am officially welcoming you to what pharmacy. You're welcome.
Kí yàn máa tiẹ̀ fẹ́ ṣe interview kọ́ lọ máa gbá mi lé ìbọ́ta bí mo bá kọ́ láàrin lé.
Oh, see. There are some please. Hello, please listen carefully. There are some things I want you to understand. Sometimes if I talk, sometimes you may not understand it. I've seen people, I've seen interviews. Nobody want to know. It's in your curriculum. And nobody want to know how you were taught. Am I communicating? Nobody cares to know. And this council exam, I am saying, don't know how it will be. Because everywhere now, the whole country is now aggressive when it comes to exam now. People are becoming, the whole bodies are becoming very, very aggressive when it comes to exam. The major close their eyes and give, you don't know who they will give, those they will call to set this year's question. Because past questions have been segregated all this while. People are seeing questions. You don't know the nature of question that will come out and how they will package questions. So if you are not grounded, if you're not grounded, that's why some things if you ask me, I'll tell you, you should know it. Look it up. Here. There's something is opening in your mind, but you may not know. Is it from that you are just sitting down and you're looking at me, I'll be telling you are putting down? No. That one you put down, greater percentage will be lost. But that one you are here. That one you looked up immediately here by yourself. See how the thing, before I now explain it, sticks more. If you are a researcher, and you understand what I'm talking about, it sticks more than you sit down. I will call you just be writing. No. Is that clear? Yes. So please don't be offended. It's well. It's well. This is the real training. The training that pays is real training. I'm training you now. All right, so let's go, please. Let's go. Now, the next one is what?
Sulfiprazole.
What is that? What that one? What does that one do? Okay, that one, please. Everything still boils down to what?
Gout.
Preventing what or tackling what? Gout, right? Yeah. But this one is what? Urico what? Suric. Is that clear? This one promotes uric acid secretion. Promote what? Uric acid secretion. Is that clear? It's secreted. Not going to trying to talk about altering oxidase xanthine oxidase activity. This one is there to do what? Promote what? Secretion of what? Uric acid. Is that clear? Removing it from the system. So that's what this one does. So it's not the answer. Is that clear? C says what? Colchicine. Colchicine. So this one, Angel read something now. She read something about what? Granulocytes. They are how many list those one under granulocyte?
How many water? Examples of
There
this.
There are 3 types of granulocytes.
Name them.
Neutrophil,
Neutrophil,
eosinophil,
listophil,
and basophil.
basophil. Good. So they are part of the white blood cells, okay? But we have the one that we are called granulocyte and agranulocyte. Two of us.
Eosinophil, basophil, and what? And eosinophil.
This one now is pure physiology, right? This one now is pure what? Physiology.
PHILS.
This one now is pure what? Physiology. Hope you know. Sorry. Now, so what does colchicine do? Remember, in fact, this one now, this granulocyte, they are involved in what? You know what is phagocytosis, right? You know what phagocytosis is? Yes. They phagocytose. They phagocytose. They do what? Is that clear? So colchicine inhibit what? The migration and phagocytosis in what? Joint. Is that clear? Inhibit the migration of this, their migration and what? Phagocytosis. Migration and phagocytosis. Migration of this granulocyte now, right? And what? The activity, their action, their migration and their action. Their migration one, and the what? Phagocytosis they do. Is that clear?
Yes.
So they prevent what? The migration and what? Phagocytosis in the joints. So this now will go away along with relieving what? Gout what? Inflammation. Relieving what? Gout what? Inflammation. Okay? So specifically, colchicine inhibit microtubule formation. Specifically, it inhibits microtubule formation that leads to all those things. So the answer is actually C. Okay? In Npce, this one is what? NSAID, right? It reduces what? Pain, right?
Inflammation,
Yeah. Yeah. What type of NSAID? What class of NSAID does it belong to? Indo what? Derivative. Good. Indo what? Do you have okay, you have got it right? Okay, you get them right? Okay. Next question is what? Question number what?
Number 9. The
Okay.
major natural estrogens produced by women are following, except
Okay.
A. Estradiol.
Diol.
Estradiol 17 beta E2. B. Estrone, that's E1. C. Ethinyl estradiol. And D. Estriol E3.
Estriol.
Estriol.
What is the answer? Okay, you threw back at me.
No, now you read the question now.
Doing
It's well.
Last we go there, okay.
But in your 300 level, did you do anything on contraceptive?
No, I think we did cancer.
On contraceptives.
Not PHC. I'm talking about AUM.
Just types.
It's well.
Amen.
Okay, please, let's look at the options, okay? Option A, estradiol. E what? From the option is E what?
E 17 beta and E2.
Estradiol 17 what?
Beta.
Is E2, right? So this one is actually is natural anyway. Is what? Natural. Is that clear?
That's number one, right?
Yes, it's the most potent natural estrogen. Please note that point. It's the most potent what? Natural what? Estrogen. Estradiol E2. In fact, all this one, E1, E2, E3, they are all what?
So you said the estradiol.
They are natural.
Yeah, they are natural. Yes, they are natural. It's only one that is not natural. Please note that point.
They are natural.
Estrogen, yes. Estradiol, estriol, they are natural. Is that clear?
Yes, sir.
But even for the name itself, even from the name you know, ethinyl estradiol, that one is what? Is not what? Natural. Is that clear? Is not what? Natural.
See now. See.
Go back to the question. You said yeah. That one is not natural. Others are what? Natural. What does number 10 say?
The major synthetic estrogens are following except A. Dinestriol, B. Diethylstilbestrol, C. Benzestrol, and D. Estradiol.
So we have cunningly mentioned about 6 or 5 synthetic estrogen. Hope you know. Are you aware? Or 5?
Synthetic, no.
Or 4? 4, 5, right?
For the synthetic,
Yes, 4. Natural, how many? 4 again. Is it 4 or 3? 3. So, dinestrol, diethylstilbestrol, benzestrol, those ones are what? Synthetic. But estradiol is what? Natural. Is that clear?
Yes.
Number 11 says what?
Progesterone is secreted by A. Ovarian follicles, B. Corpus luteum, C. Granulosa and theca cells, and D. All of the above.
What is the answer?
Corpus luteum.
Wow.
It's our body.
See it here. Is here. See her face. You know what I'm saying? Okay, the AM is not AM in again. It's well. All I know is that it's well. Don't worry, we'll take it step by step, okay? Don't worry. You know where it is with time. Now, option A says what? Ovarian what? Follicles. What does ovarian follicle? What is produced there? Estrogen now. Estrogen, yes. Estrogen. Now you know that now I don't know, God is so wonderful. Sometimes if people say there's no God, I'll just looking at them. If people say there's no, I'll just looking at them. Everything is perfectly made, organized. In fact, it's we human being that is the problem of this world. We human being that scatter everything in it, even from our own system. We scatter it. After ovulation, immediately after ovulation, the body will start preparing to accept baby. Everywhere, the wall of the uterus will start getting preparing for what? Implantation. Peradventure, if there is what? Fertilization. So that once there's fertilization, the result of fertilization will see where to do what? Implant. The body is already will start preparing for that. But if eventually no fertilization, they will shred. That what? They will go that way again as what? As what? Menstrual flow. You see how wonderful God is. You see how this is not accident. It's not what? Accident. It's not accidental. It is planned. But we say no. We want to take the one that will change it the way we want it. And at the end, we'll see be the people to do what? Cry.
This what's changing it? What's changing? It's not just to change it.
Okay. Oh no. Since you take, but those that take every weekend, they go and take a post-pay.
Oh, okay. I even want to ask.
Or they all this is to keep changing, scattering the whole system.
Okay.
Is that clear? Now I'm just trying to get to where the couples what lithium. That's why I told this simple word, this short story. Now basically, what is it? If what?
They say you are taking this to scatter the distance, but we cannot be giving birth to 20 now.
You don't understand what you don't understand. No matter your justification, you are thwarting that thing. Simple. That's what you are doing. No matter your justification, I'm not asking you your reason. What I'm saying that you are thwarting what God has put in place. Simple. And it comes with effects. We all know about it. So your reason is your business. Your reason for taking it is your business. But the point is that this thing that God has made, you are doing what? Thwarting it. Simple. That's the fact. Okay, today we are crying now. We need to plant trees. We need the air is polluted. We need trees. Who put out that trees? Still human being. The same human being is crying again. We need trees. We need the same human being. Are we not confused? What do we want?
They go and feel Atlantic Ocean.
What do we really want? The same human being is go and start scattering things God has created. That's why if you see those people that are enlightened and they are rich, where to do enlightened, see where they go to rest. They go to where there's trees
And
water.
They go at that side.
And we pack ourselves here. We pack ourselves here. Sometimes some things we develop, you don't even know where it came from. We human beings are the issue problem in this world. Not even animals. They follow normal natural course. It's we. So whatever reason, I'm not asking your reason. The point is that we scatter everything by ourselves, and at the end we cry more.
Even this mud.
We cry more.
Has his own significant something on health. And everything that this armor, but all these blocks, these bricks that were in cement, everything.
Sir, funny enough, all those houses that you built
Of course, now we all know that one now.
Because even for you to hear, don't hear the gospel.
All right, let's go back. Thank you. Let's go back. I continue. Alisa. Okay, now so after ovulation, basically, after ovulation, the couple's lithium is formed. Is that clear? After ovulation, couple's lithium is what? Formed. So basically, what happens is that now this is what is responsible for the what? The secretion of the what? Progesterone. Is that clear?
Yes.
Secretion of the what? Progesterone to prepare To prepare for what? To prepare for what? What is it? Are we together?
Yes, sir.
Okay, please though. So to prepare the endometrium for what? Pregnancy, that is implantation. Is that clear?
Yes.
Is that clear?
Yes, sir.
After ovulation, couples luteum forms, progesterone release to prepare the endometrium for what? Pregnancy. Is that clear? Because next thing that was supposed to happen under normal circumstances should be what? Fertilization. And after fertilization, the next that should happen is what? Implantation. And where will they get implant? In where the uterus, endometrium, right? True or false? So the body will prepare for it, for the implantation. That's why if you have issues, you have your pelvic inflammatory disease, you may be having issues getting what? Pregnant. Because implantation will be problem. True or false? Because the endometrial wall will have issues. True or false? Because it is already what? Inflamed. It's a problem. So those that are treating infection.
Why are you looking at that?
There's no how you remember the infection. It's twice a year.
So treat it well. That's my point. and avoid things that lead to that infection. But if you treat it today, hello, ask yourself what causes that infection. Run away from it. If you treat it today and go back to that caused it will do what? Come back. You keep treating. Before it was going on, PID was setting. Right? Tomorrow you start saying that you don't know. Your mother-in-law is bewitching you. Nobody's bewitching you.
But there's mother-in-law bewitchment.
Okay now.
There is.
Okay now. Continue. Sometimes we create things that don't exist and they will start existing. Our mind is so powerful. If you don't know it today, our mind is so powerful. Sometimes that don't exist, you create it by yourself, and it will start what? Existing. How do you think they create? We are gods. We are what? Gods. Small G. We are gods. We human beings are gods. Yes. How do you think they create all these things? They carve something and speak into it. Speak into it consistently, and it will start working. You'll be like, how is it possible? You are only less than God, though. Even angels are under you. If you don't know it today. Know who you are. You are powerful. You under angels.
Psalm 8 verse 4. You are created a little bit lower than the angels.
Okay, now. Is that right?
Creation. But okay, what the master said that we are like God, that we created God like God. We are God like. Is angels look like God? No.
Small dogs, knowing something going on.
Now like God.
Me!
No, angels look like God.
I'm God every time.
On earth. Beautiful and
wonderfully made.
That one is. No, it's an argument for another day. Let's not.
No, I'm not arguing with you. I don't argue.
You don't have
I'll say my own. I'll say my own. If you believe, you know who you are. They are there to serve you. They are there to do what? Serve you.
We are more than angels.
They are there to do what? Serve you. If you don't know it today, know who you are.
I am a child of God.
Do you know the issue? Do you know the issue? The issue that we don't even know who we are. That's the problem.
I will choose you.
Until you realize that.
I am who God said I am.
So I've calmed down now a bit. So let's continue.
What's that, guys? Oh, yeah, let's continue.
The answer is me. No, that's not me. The answer is
I wonder. Who come late? Hey, listen carefully. By right. Hello. By right, it should be somewhere there,
Yes.
waiting for us. So keep quiet. People are here since 8:30,
Yes.
and they need to sweat themselves. We have shut her up. All right. So next we are okay. So the answer is what? B, right?
Yes.
Corpus what? Lithium. So the granulosa cells and what have you, all those ones are for pre-ovulation, estrogen preparation, pre-what? Ovulation. Is that clear? So next question is what? 12, okay.
Non-contraceptive clinical use of progestin are following: A. Hormone replacement therapy. B. Dysmenorrhea. C. Endometriosis. And D. All of the above.
What's the answer?
A.
A is what?
It's all of the above.
All of the above.
For dysmenorrhea, if you use this combination 3-level megasterol, it works.
And for endometriosis, they give what's it called? CAC, combined action contraceptive.
So the answer is what?
All of the above.
Good. There you go. I like that. That's good. Next question.
Number 13. Indicate the skeletal muscle relaxant, which is a depolarizing agent.
Okay.
A. Vencuronium. B. Scopolamine. C. Succinylcholine. And D. Hexametonium.
Please silence your phone, please. Please silence your phone, please. Again, please.
Indicate the skeletal muscle relaxant, which is a depolarizing agent. A. Vencuronium. B. Scopolamine. C. Succinylcholine. And D. Hexametonium.
Succinylcholine. Succinylcholine. Say it.
Succinylcholine.
Some call it succinyl.
Sounds like sushi.
Some call it succinylcholine. Can you find this in the bed? What are they doing there? Oh, wow.
Peace, Deba.
Succinylcholine. Is it 12 already?
No.
11:47.
She wants to be the first
Indicates
one.
the skeletal muscle.
So we discussed this in our I think last 2 classes, right? So tell me, what is the answer? C is what? Succinyl what? Choline. Yes. We discussed it because succinylcholine act as a what? Depolarizing what? Neuromuscular what? Blocker. So it mimics what? See what it does? It mimics what? Acetylcholine. Is that clear?
Yeah.
At the neuromuscular junction, but it's not actually what? Acetylcholine. So it mimics acetylcholine at the what? Neuromuscular junction. Is that clear?
Yeah.
So all those vecuronium is non-depolarizing. Scopolamine, hello? Scopolamine is anticholinergic. Is that clear? Hexametonium is ganglion blocker. Ganglion. You know you are what's the ganglion in your nervous system? So tell me, what is ganglion? What happens at ganglion? Let me sit down a bit. Someone should check it up and let us know. Ganglion. What's a ganglion? What happened at ganglion? And what are
Ganglion is a lump or swelling that can appear on the hand.
no.
Is it this one? Okay, it's a collection of neuronal bodies
Okay.
found in voluntary and autonomic branches of the peripheral nervous system.
Yes. So hexametonium is a ganglion blocker. So it's not used as what muscle what relaxant. Okay. Scopolamine is anticholinergic. It's not used as what? Muscle what? Relaxant.
So now, sir, how ganglion cyst now?
No.
It's not related to what we are
No.
talking right now.
Lymph node.
It's a different cell.
Inflamed lymph node. No. That one is inflamed lymph node, indicating a disease has maybe infection has come in. Yes. Anytime you see your lymph node, it can be inguinal, it can be here, it can be brachial. And anytime you feel it, know that you are about to fall sick. Yeah, just know that you are about to fall sick. Just you help yourself.
Is it when you feel it?
So I want to ask a question.
Okay.
I heard that the location of the lymph node can actually signify where the infection is or where the part of the body that the person is.
Yeah, that area where the drainage, because they drain with that where the part that the node, that lymph node as well now, it means that the part of the body that drains that part, that lymph node control is drainage. There's something is wrong at that place. It's a sign that something not happen. It's either they are about to conquer your, in fact they have even conquered your. Once I see it, I know that something is setting in. To me, I don't know how. Once I notice it, something entered my system, and that thing is actually doing a wonderful job. That thing is doing a wonderful job.
Yeah, I don't feel anything.
Alright, number 14 says what?
The effect of the drug on parasympathetic function declines rapidly in all organs except A. Eye, B. Heart, C. Smooth muscle organs, and D. Glands.
Again.
The effect of the drug on parasympathetic function declines rapidly in all organs except A. Eye, B. Heart, C. Smooth muscle organs, and D. Glands.
What's the answer?
Glands?
Glands?
I mean, that's the game for them.
To compare to the eyes, other ones, it clears, the effect clears rapidly to compare with the eyes. The eyes stay longer. Is that clear?
Yes, sir.
The effect is stay longer in the eye. Is that clear?
Yes, sir.
So drug effect on the eye stays what? Longer. It has a slower. Do you know why? There is a slower clearance. You know, if a drug clears faster from the system, that means the effect doesn't stay. It's short-lived. It's short-lived what effect? Is that clear? But if the clearance is slow, the effect will be what? For long. Is that clear? So that's in the eye now. There's slower clearance in the eye to compare with the other part of the body listed in the options. So because of the slower, now that is where the effect will more what? Prolong. Is that clear? That's the answer. That's why it's the answer.
Wow. The answer is what? Wow.
Eye.
Wow.
So the parasympathetic effect decline more faster in all the one they had the smooth muscle organs and the glands, but the eye. Example of parasympathetic effect in the eye is what? Tell me.
Dilation of the pupil.
By what?
So dilation of the pupil.
By what?
By what?
Example of drug that can cause it.
Atropine.
What's another name for that dilation?
I don't know.
Mydriasis.
Mydriasis, right?
My dear.
My dear. Hey.
Wow.
You see, that's why it's not going to come late. In fact, from next week, okay, I will not be around next week. From next week, Let's say it.
Can we move our time to maybe the 9:30? Genuinely. No, sir, genuinely. Genuinely. Number one, the weather. Number two,
The weather.
the weather.
Baby, the weather.
The weather.
Baby, the weather. Getting good.
I woke up early. I had to sleep again.
See,
It's just.
hello, am I communicating?
Yes, sir.
Decide.
Sir, tell me.
My own is the time people decide. If I come here, be here. That's my issue.
Yes, sir. Sir, tell me.
Sir, give us 10 o'clock.
No, I'm not giving you any time. Oh. You decide.
Then.
I won't give you time. Please decide by yourself. As a class, decide.
You don't eat. You don't have
Wait. Hello. When we are done, I will soon done. If I'm done, I will go. You will have a bit now. Wait. Decide. Your class rep will communicate to me.
Okay.
The time decided. All I know is that day I am here for April. Anytime you decide, I'll come here the time, exactly time you decide. Mama, I'll come here and stay.
Yes, sir.
So that's my own. So it's not what we discuss here. Discuss. Whatever you could decide, she will let me know. Is that clear?
Yes, sir.
Yes, sir.
So the answer to number 14 is what?
Eyes.
Eyes.
Not eyes.
So, Waya, pronounce this. Mydriasis. Mydriasis. Is that clear? That is the definition of the word. The words. Poopy, right? Mydriasis. So it's one of the parasympathetic effect of the atropine in the eye. Is that clear?
Yes.
Of course, when you start going to the eye conditions, which is not eye conditions like what? Itching. No, it's not itching. What do you think? What?
Maybe if you want to do surgery.
Is it glaucoma? No, it's not cataract. It's more of what glaucoma like what cataract. Cataract is just something is covering exactly. You know, we have this pressure. The pressure
Intraocular pressure.
can be increased there, right? So if this dilatation can do what, relax and do the pressure will do what, come down. Is that clear? So when pressure is much, it's a problem in the eye, right? Is that clear? Next question says what?
Patients complain of dry or sandy eyes when receiving large doses of
Please, start afresh. You say what?
15. I said away. 15. Patients complain of dry or sandy eyes when receiving large doses of A. Atropine, B. Hexametonium, C. Pilocarpine, and D. Carbachol.
What's the answer? Bagam. Do I know? But wait though. There are some questions you will see. You go back to what you have discussed. It gives you a clue to answering this question. It's simple. Why? We have discussed some things about atropine. What atropine does.
But we did not say this. The side effects talked about in atropine.
We must not say it the way it is. But you can figure it out. Yes, now. This inside this call, what is it for? Figure it out. Tell me the answer now. Why is it atropine?
Because we said that atropine has it's good for dilating the but it has plenty side.
It's a side effect. See, any drug we are taking, effect is effect. Please listen carefully. Please, am I complicating? Please let me put you through one or two about pharmacology, actions of drugs. Please listen carefully. Effect is effect. Any drug you take has effect in the system. Now, when that effect, it has many effects. You can have one or two, three effects. Since atropine has effect on the parasympathetic nervous system, it will affect the parasympathetic nervous system in different ways. The one you need at that point in time becomes the action you need. The one you don't need becomes side effect. If it becomes too much, that it has become dangerous to the system,
Toxic.
it becomes adverse effects. That's what differentiates between what side and adverse. Is that clear?
Yes, sir.
Good. Now, if atropine has the parasympathetic effect, fine. What will now happen? It also have effect on the side of what? Lacrimal secretion, tears. Tears. Is that clear? Now it affects what? Tears what? Production. Are we together? It affects what? Tears. Let me if you ask, what is the main effect of atropine in the parasympathetic nervous system?
Dilation.
Dilation of the weight.
Good. Atropine has on the side effect now. It reduces what? Brings down what? Tear production. Is that clear? Because if you bring out tear production, the eye will become drier,
Blurry.
and you start feeling sandy effect. Is that clear? That is a side effect.
End of discussion.
Am I communicating?
Yes.
In the eyes? Remember, you are using it to do what? Help you to do what? Cause what? That at the same time, it causing this one. Is that clear? So you now know how to dynamics on how to use it and what you should expect. Know that okay, this is happening because of what I'm using. No problem. By the time I'm done with this treatment, it to do what? The patient will not be afraid. Is that clear? But it can be. It is tolerable, but it becomes an issue if it's that
Not
more.
me.
Angela.
Okay.
It's not true. You are looking at Angel.
Is it Angela picking and saying yes?
No, it's Angel. It's Angel that's saying yes.
I'm understanding now. Let me.
Leave her alone now. Waiting. She's understanding now.
That's my way of assimilation. And let me assimilate.
Are we together?
Together we shall.
So the answer is what?
Atropine.
Atropine. Now, the second option B is what?
Atropine causes.
No, option B. Sorry, option B is what?
Exametronium.
I've talked about what? Exametronium, right? That's a ganglion what? Blocker, right? Ganglion what? So it does not affect tear production directly anyway. The other ones, pilocarpine and what? Carbachol. Those ones, please. Pilocarpine and carbachol, they stimulate what? Stimulate what? Secretion. Are we together?
Secretion.
Yes.
Or water.
Lacrimia.
When you say secretion, this one inclusive now. Tears inclusive. If you say secretion, is that clear?
Okay, so they stimulate secretion of tears.
Secretion is secretion controlled by the parasympathetic nervous system. Now, one of those secretions I mentioned is what? Tears, right? From the what? From the what?
From the tear gland.
Hey, what is going on here? Sorry, I don't handle you as what is it called? First year students. You put it from a form of A now, waiting. There are things I will say, it look as if, is this man looking down on us or what? You are big, yes. You are.
Cut by cut, according to the sense.
You are senior citizens now.
I don't reach.
I will not senior citizens.
No, not enough.
So far, this is concerned. Just who you are.
No, you are not in our 60s.
You know what?
You are not in our 60s.
No, we're not talking about Nigeria plan. We are talking about this. Look at this one. What is Angela doing? 16 says what?
16 says that atropine causes meiosis, a reduction in ultraocular pressure and cyclospasm. B. Mydriasis, a rise in intraocular pressure and cycloplegia. C. Meiosis, a rise in intraocular pressure and cycloplegia.
What are you doing? Come and sit down here. Sharp.
I'll sleep.
Sir, D.
Go sleep. Then stop dancing.
Mydriasis, a rise in intraocular pressure and cycloplasm. Sam.
What's the answer?
I don't know. A sounds right.
What's the answer?
The option B and D is the same thing.
Yes, option B and D is the same thing.
You said what?
Option B and D is the same thing.
That's true. No, it's not the same. Mydriasis and meiosis.
B and D. Okay, it's not the same.
It's not the same.
My eye don't get it.
It's not the same thing.
It's not the same thing.
So what's the answer?
We don't know.
She's a medical
What is the answer? Huh? But we have discussed this here now. Why do that? Do this?
So the answer is B.
Are you tired?
Yes.
But let's finish it. But let's finish it.
Are you tired?
Yeah.
Maybe she
The
shall
answer is B.
The answer is
B.
the Lord is our shepherd.
The answer is what?
B.
B.
Mydriasis, a rise in intraocular pressure
Intraocular
and
cycloplegia.
cycloplegia. Yes.
Does mydriasis actually cause rise in intraocular pressure or decrease in intraocular pressure?
It's decreased, but where did meiosis come from?
Mydriasis. I'm talking about mydriasis.
Meiosis is to dilation.
Dilation of what?
Of the pupil.
Then if it dilates, if the pupil dilates, what effect does it have in the intraocular pressure?
Yes.
Are you sure? Are you sure?
Yes. Because when there's much intraocular pressure, like there will be pressure on the eye, and it will kind of.
Are you really sure? Where is the pupil?
The pupil is in the eye.
No, let's go to the structure of the eye. Where is the pupil in the eye?
This is
Where
the
exactly?
middle of my eye like this.
Yeah, where is it?
That black thing.
So if it dilates, what happens?
If it dilates, it will open more and let in more lights now.
So intraocular, what happens?
It will increase the
Let's rise the pressure.
See, they see. I'm sorry to say this. You don't cram from oncology.
I swear.
Try to link it up. That's why I am. The way I'm trying to. Those that don't like thinking may not like what I'm doing. Please, are we together? And as a pharmacy technician or pharmacist, you meet challenges. You must learn how to link up these things. It's very important. You lead them up. If the pupil dilates, fine. What is the effect in the intraocular? There's more pressure there now. It's not true. There will what? More pressure. So atropine blocks muscarinic what? Receptors in the eyes. So and leading to what? Direction of the what? Pupils, mydriasis, and paralysis of what? Accommodation, and increase in what? Intraocular what? Pressure. So cyclo what? Plegia is paralysis of what? Accommodation. Is that clear? So the answer is what? B. Meiosis is the opposite of what?
Mydriasis.
Are we together? Meiosis. Are we together? Meiosis. Not meiosis. So in your not meiosis. Meiosis.
It's not meiosis in biology.
It's meiosis. Yes. MIOS. Meiosis. So I've said the answer here now. So the answer is what? B. Meiosis. 17 says what?
Circle the main apples of peptic ulcer treatment.
You said what? Second what?
The main approach
Of peptic ulcer treatment.
A. Neutralization of gastric
Wait. This class is becoming noisy. See, listen carefully. Are we together? If you are tired, we can stop here. We'll continue next time. No need trying to force things when it's not entering.
So let's do this last one.
I don't believe in forcing things that is not entering. At least you are not how do I put it? I believe in cut it short, be consistent, than piling it up. Then I will be talking to myself. When I'm done, I will go thinking that I've impacted without knowing that I didn't impact anything. It makes no sense to me. And I said that one of the signs that of brain that is fed up is distractions. You won't even know when you start either getting yourself distracted or distracting others without even knowing. It's not intentional, it's nature. Please, let's focus, please.
So, sir,
Read the question again, please, no verse.
Circle the main approach of peptic ulcer treatment.
Okay.
A. Neutralization of gastric acid.
Okay.
B. Eradication of Helicobacter pylori. C. Inhibition of gastric acid secretion. D. All of the above.
What is the answer?
All of the above.
Is all of the above now, because all of them are involved, right?
Yes.
So you can reduce acid by you can reduce acid by neutralization.
Gastric acid.
Stand here. You can reduce acid by what? Neutralization. You can reduce acid by what?
By neutralization.
You can also reduce acid by.
Eradicating
It's not true. How can you reduce acid by
inhibition of gastric acid secretion
through what?
Through
Proton pump.
proton pump
inhibitor.
H2 blocker.
And that one again through acid. Which other way can you reduce
Antacids.
that
Antacid is
is
neutralization.
is H2 antagonist in there and come?
H2 antagonist
Yes,
inhibition.
because the receptor that produces gastric acid.
Yes, that is example to
So in general, you can see what. Hello.
Sir.
What H. pylori does is not. H. pylori is direct to the defensive what mechanism. Is that clear? Not through acid. Is that clear?
Yes.
A lot of people have this H. pylori, you know.
Yes.
All right. So what is the answer now? The answer is all of the above. Number 18.
Gastric acid secretion is under the control of the following agents except A. Histamine, B. Acetylcholine, C. Serotonin, and D. Gastrin.
What's the answer?
Serotonin.
Is serotonin. All others have effect with what? Acid what? Secretion. Is serotonin does not directly stimulate acid what? Secretion. The answer is C. Number 19. Hope you're marking.
Yes. Number 19.
19 says what?
Indicate the drug belonging to proton pump inhibitors. A. Pyrazepine, B. Ranitidine, C. Omeprazole, and D. Trimethophan.
Your answer.
What's the answer?
Omeprazole.
Omeprazole inhibit what? Hydrogen potassium ATPase what? Enzyme in the stomach what? Parietal what? Cells. So that's what you call proton pump now. Okay, you think proton pump is a tap?
No, they don't say proton pump. They did not tell us that this.
I'm telling you now what is it?
Okay, sir. Hydrogen.
Is hydrogen ion / potassium ATPase.
Hydrogen.
Ion potassium ATPase enzyme that is there, that is involved in this pumping of ATPase, ATP, then ASE, small letter.
ATPase.
It's an enzyme anyway. So this is what they inhibit. Because this is what is involved in that active transport of what hydrogen. Is that clear? You know, we have active transport and passive transport, right? So this is what they actually act on to prevent what a hydrogen ion coming, because hydrogen ion is involved in this hydrogen acid production. Hope you know. You are aware now, right? Good. So the answer is what? 19. What is the answer to 19C? Pyrazapine is M1 blocker. Ranitidine is H2 what? Blocker. While trimetaphan is what? Ganglion blocker. So the answer is what? C. Omeprazole. Number 20.
Number 20 states, all of the following agents intensify the secretion of gastric glands except A. Pepsin, B. Gastrin, C. Histamine, and D. Carbonate mineral water. Histamine.
What is the answer?
Histamine. How are you not blocking H2?
All the following intensify. Intensify it except that means the one that does not intensify this.
Pepsin.
Ẹ̀yin wọn tiẹ̀ máa ń gbọ́ máa ń ṣe lọ́yọ̀
Kí lẹ sọ?
ẹ bá ti rẹ́yìn báyìí èyí ẹ̀.
So pepsin is a digestive what? Enzyme, right? It's not about what? Secretion. So other ones apart from septrin. So you just say septrin?
Yes.
Pepsin. Other one with the exception of what? Sepsin. So the answer is what? Pepsin. Okay? Next question. 21.
Which of the following groups of drugs is used for asthma treatment?
Okay.
A. Methylxanthine.
Okay.
B. M-cholineblocking agent.
Okay.
C. Beta-2 stimulant. And
Okay.
D. All of the above.
What's the answer?
C.
C.
What's that your feeling?
Please be looking at all the other options now. Please, hey, if you make mistake and what you see there is all of the you will fail. Look at the other options. So please, don't just pick one that look at like the answer and mark it. Look at the other options. Please look at the other options. Good, yeah, please. So all the other ones they are all what for asthma. So the answer is all of the above, please. 22.
Sample the drug belonging to non-selective beta-2 adrenomimics. A. Salbutamol. B. Isoprenaline. C. Samiterol. And D. Tebutalin.
What's the answer? Bagam. Circle the drug. Wait. Circle the drug belonging to non-selective beta-2 mimics. A. Salbutamol. B. Isoprenaline. C. Samiterol. T. What is tabutalin? What do you understand by the term beta-2 adenomimics?
It mimics
Is it beta-2 blocker or beta-2 agonist?
Beta-2. It's going to be agonist. Because it's mimicking it.
Give me examples of beta-2 agonist. We discussed this in this class. I don't like this. We discussed this in this class. Give me an example of beta-2 agonist and a beta-2. We discussed it up to 3 different classes. I will sit down and listen to you. You must tell me this one. If you like, be hungry. It's a business. No, if I can go and eat. Let those that are interested tell me this. I discussed it, and we had issues over it. I sorted it out because this thing can be confusing. Now again, the same thing is happening again. I won't take it. Tell me. Check your material again, or you go online and tell me. With respect to asthma, is it beta agonist we use or antagonist?
It's antagonist.
Antagonist. Is it antagonist we use?
Work against.
Beta agonist as antagonist.
I want to know. I am waiting. What do we use in asthma treatment? Is it beta agonist or beta antagonist? Beta to antagonist? If it is, tell me an example of it. Huh? Are you asking me? Are you telling me which one?
Say it.
Example.
Paracetamol, salmeterol,
this one.
Read it now. It's not me. You're looking at me. Now, where do we use? I also talked about where we use, because I know that it causes confusion. That's why I took my time to explain. Where do we use beta antagonist? Where? Which part of the body? An example. I gave this example and I explained it. Yes. I asked me. Tell me. Don't ask me. Tell me, and give me an example.
Blood pressure.
Give me an example. Now you come. Let me form my hand like what I don't know. You went out. So now, from these options in number 21, right? So which one is not there? They say belong to non-selective. Which of one belonging to non-selective beta 2 I don't know what? Mimics. I agree. I don't mimics it. Talking about what? I didn't beta 2 agonist, right? I agree. So which of them is non-selective? Others are selective beta 2. Others are selective beta 2. Except isoprenaline, which is not selective. What's another name for isoprenaline? Badam. Check it up now.
I don't know where it is isoprenaline.
Is a popular name. Just check it up now and tell me. So isoprenaline stimulates both beta 1 and beta 2 receptors. That's why it's not a non-selective. It's a non-selective. Is that clear? It stimulates both. Isoprenaline, not as isoprenaline. I said isoprenaline. Look for another name for it. It simulates both words, beta 1 and what? Beta 2. Is that clear?
Yes.
Is that clear?
Yes.
So it's non-selective. While others there are what? Selective. Okay? This is the fourth time we are discussing. If I come back in the next 2 weeks, be looking at me as if we have not mentioned it again. Now, so the answer to 22 is what?
B.
22 is B, right? Good. 23, oh yeah.
Select the side effect characteristics for non-selective beta 2 adrenomimics. A. Depression of breathing center. B. Tachycardia. C. Peripheral vasoconstriction. And D. Dry mouth.
What's the answer? You should tell me what the answer should be now. We talk about it. If you reason with me since I started this class, if you're following my drilling now, you should be able to answer this question.
Depression of breathing center is caused by opioids. That's narcotics.
Okay.
One. Tachycardia. That one is for this thing. It's not the one causes this thing thing that is caused by it's bradycardia that it causes, like all those things in and co.
Okay.
Then peripheral vasoconstriction. Can it be? No, vasoconstriction, that's the vessels. Can it be?
It's not.
It's not, so it's dry mouth.
Why is it that the dry mouth?
Because the other
Do they have we are talking about the dry mouth, is it a parasympathetic effect or sympathetic effect? We are talking about sympathetic now. Adreno is sympathetic, not cholinergic. Please, adreno, anytime you hear adreno, it's talking about what? Sympathetic. Is cholinergic, that is what? More of what? Parasympathetic. All those things here, all those secretion, mucus, all those has business to do with more of what? Cholinergic. We are in adreno now. It's tachycardia now. Do you know why?
Why?
It's both beta 1 and beta 2. Beta 1 is more toward the heart now. Just put 1 and 2 together. Pharmacology is sweet, though. It's a sweet course. It's not about putting 1 and 2 together, reasoning it out. You see the answer. Yeah, it's not. You don't cram it. I've already told you that this one has both beta 1 and beta 2 effect. Beta 2 is more on the what? Respiratory, whatever, for asthma. But beta 1 is what? Cardio, more on cardio. I remember, it's adrenergic now. It's not antagonist, it's agonist. So if antagonist is used for bringing down the, what is it called, slowing what? This is from increased what? Heart rate. Remember, we have even discussed something like that here when we discussed theophylline. Is that clear? This one now will now cause what? More contractility. This can lead to what? That contractility, increase in myocardial contraction, can lead to what? Dyspnea if care is not taken. So he says that effect. It can tachycardia can do what? Setting. It can setting. So non-sedative agent, they cause what? They have effect in the heart. They can cause what? Tachycardia as a side what? Effect. Depression, all those ones, vasoconstriction, beta 2 causes dilation.
Not constriction.
Is that clear?
Yes.
Of course, you know now. You know what happens in the bronchospasm now. It's more than dilation, not what.
Not constriction.
So dry mouth, I think I mentioned here now. Dry mouth is acetylcholinergic effect, side effect, not symptom. Not adrenergic or sympathetic effect. No, dry mouth is more of parasympathetic. That is cholinergic effect. Please know that point. Is it clear?
Yes, sir.
24 encore.
Pick out the bronchodilator drug related to xanthine. A. Atropine. B. Oxyprenaline. C. Adrenaline. And D. Theophylline.
What's the answer? It's theophylline now. So who know this one? It's theophylline. Is methyl what? Xanthine, right? It's a methyl what?
Xanthine.
Theophylline is a methyl what? Xanthine. And it relaxes what? Bronchial what? Muscles. True or false?
True.
Taking care of the bronchospasm, right?
Yes, sir.
Atropine is anticholinergic, right?
Yes.
Oxyprenaline is beta agonist. Oxyprenaline is beta what? Agonist. Adrenaline is both alpha and beta what? Agonist. Adrenaline is both alpha and beta agonist.
Oxyprenaline
is beta agonist. Now the last question says what?
Pick out the bronchodilator drug belonging to the sympathomimics.
Okay.
A. Isoprenaline. B. Epinephrine. C. Atropine. And D. Salbutamol.
What's the answer? What is the answer?
Isoprenaline is adrenaline.
What's the answer?
The answer is
The other is what? If you know answer this one, I will knock you head one by one now. If you know answer this one now, I will knock you head one by one. What's going on here? What's the answer? Sabutamol now. Sabutamol. They give you the answer by mentioning 2 words. Bronchodilator, beta agonist. What else do you want to see?
How many days are left?
You're running. Okay, now keep running. The answer is what? D. Asoprenalin nearly entered, but is not selective. Is that clear? Because what causes that thing is that selectivity, that selective beta 2 effect of what? What causes the bronchodilation more is the selective effect of beta 2 what? Agonist in the bronchial muscles. So causing what? Broncho what? Dilation. Ephedrine is less selective also, but used mainly in nasal decongestion. Ephedrine. You see that one in nasal suggestion. Is that clear? So it's less selective. But atropine is not adnergic, it's more of what? It's what? Cholinergic, right? Parasympathogenic, not sympathogenic. So it's cholinergic, not adrenergic. I think we've come to the end of our class today. Do you have any question to ask? Please, Mark, let me look at your scores before I go. Mark and submit. Let me see what you did. Those that were in class. Let me see. Those that came in. Let me see what you used. Whether you even tried at all.
You don't even try.
Hey, you are welcome to real. You are welcome. But it's well. Nobody even got 50.
For us to score this one, French.
Only but 8. You put you could not try so hard. I will not lie to you. Please, next Mike, I was saying it will be next. Have you recorded this?
Yes.
Give me your take.
I want to go 50. I will try.
You try.
Go first.
My life will
You know where you are. We are coming.
All right. So see you next
2 weeks.
Next 2 weeks.